Hello and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Juliet Edgcomb will present detection of suicide-related emergencies among children using real-world clinical data. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of over 190 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the Foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such great impact is because we do not limit our focus to one illness or condition. Since 1987, the Foundation has awarded $450 million to fund more than 6,500 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, obsessive-compulsive disorder, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Juliet Edgcomb. Dr. Edgcomb is assistant professor at the University of California, Los Angeles. She was a BBRF 2020 Young Investigator. Our webinar will begin with Dr. Edgcomb's presentation, which will then be followed by Q&A. To submit your questions, please use the question tab on the control panel of your screen. Please feel free to submit your questions at any time. Following the presentation, I'll ask as many questions as possible in the time allotted. And now, I'm very pleased to introduce Dr. Edgcomb. Juliet, the floor is yours.
Thank you, Jeff. Hello, good morning, good afternoon. I'm Juliet Edgcomb. Welcome to this Meet the Scientist webinar. And the title of my talk is Detection of Suicide-Related Emergencies Among Children Using Real-World Clinical Data. I'd like to start by acknowledging our research funders and community partners who I show on this slide who have both inspired and made this work possible. Please note that what I share today is my perspective as a physician scientist, and it is not designed to formally reflect the views of these organizations. And some of the research I'll present today was funded by a Brain and Behavior Research Foundation Young Investigator grant. Before beginning this talk, another disclosure I need to make is that I am a child psychiatrist, and I see children who present to care for mental health related emergencies, including suicide and self-harm, and this experience informs my views and approach. I'm also a parent. During this talk, I welcome your comments and questions. If you use the chat function, I'm going to save some time to try to address some of them and also include my contact information at the end of the talk and welcome your thoughts and comments and questions. So this is the format for the hour. I'm going to start by presenting to you some of the challenges we face in addressing youth mental health and suicide prevention. And then I'll highlight some current science that takes a journey of what we know and what we need to better understand. And then I'll touch upon some of the challenges that remain. And finally give a sense of the roadmap ahead. And then I'll end with some takeaways. So suicide is a leading cause of death of people 10 to 64 years old. Suicide is a major challenge to public health in the United States and worldwide. And between 2000 and 2020, those 2 decades, suicide rates rose 30%. Across the United States, tragically, 1 in 13 children attempt suicide before reaching adulthood, and 1/4 of young people who die from suicide. Rates of suicide are also rising precipitously for children in elementary and middle school, with a tripling of rates between 2007 and 2018 of suicides of children 10 to 14 years old. While these numbers are stark, they're juxtaposed with hope. And that is that most Americans believe that suicide is preventable and that the actions we take as a society, nationally and globally, and as healthcare providers can meaningfully reduce the risk an individual dies by suicide. In fact, 94% of US adults believe that suicide can be prevented at least sometimes. One of the major challenges is that suicide death reflects only a portion of the problem. Substantially more children and adolescents are hospitalized or treated in ambulatory settings like emergency departments for non-fatal self-harm like suicide attempts, or are not treated at all. Also, there's disparities in access to mental health treatment that may contribute to differences in who makes it to care. To start to organize our thoughts around risk and protective factors, this is the socio-ecological model of suicide prevention, and it organizes these factors into 4 different levels. Risk factors that include the individual level, things like having had a previous suicide attempt, a history of depression, a history of adverse childhood experiences. The relationship level, like bullying or loss of relationships. The community level, lack of access to healthcare or community violence, and the societal level, stigma associated with help seeking. On the flip side, we have protective factors that can also be grouped similarly: individual, effective coping, having reasons for living, relationship, feeling supported, feeling connected, community, connected to schools and availability of high quality child mental health care, and societal, reduced access to lethal means, cultural objections to suicide. As you can imagine, this model looks a bit different for children than for adults, because these risk and protective factors occur through an arc of development, right? That individual, relationship, community, and societal factors impact children a bit differently than adults. And in fact, the pathways to preventing suicide in children differ somewhat from those of adults. There was a question someone posed in response to this talk that was about pre-adolescence, so younger children, that they have this perception that society has this perception that they don't experience suicidal thoughts or don't have the cognitive capability to comprehend the nature of death. And really now it's recognized that not only do pre-adolescent children experience suicidal thoughts, but also that the risk and protective factors, the ways we can help them, vary by age. So for example, among pre-adolescents, being male, experiencing child maltreatment, or having a diagnosis of ADHD are all associated with risk of suicidal thoughts. While parental support from parents and caregivers, is really quite protective. So the CDC Suicide Prevention Resource lists many evidence-based interventions that are specifically adapted for children, like social and emotional learning programs adapted for children to resolve problems in relationships or at school or with friends. And while suicide prevention extends to many different settings, school, home, a foundational setting where we have to get it right is in healthcare. Lack of access to specialty mental health care is a huge contributing factor to the underuse of mental health services. Most children with mental health conditions and even suicidal thoughts and behaviors receive care in general settings, particularly in emergency departments. Tragically, most children and adolescents who die by suicide have had a healthcare visit before their death. More than 1 in 3 young people who dies of suicide had a healthcare visit in the month before their death, and nearly 9 in 10 had a visit in the prior year. So there is promise that these healthcare visits can serve as a critical point of intervention, not only when a person is in crisis, but in preventing the child from reaching that point of crisis. And prevention of suicide death ultimately hinges on early detection and intervention. So toward this goal, the National Strategy for Suicide Prevention calls for surveillance of suicide and self-harm events and the use of data to inform action. Which leads us to a question: how do healthcare providers delivering care in a general health setting, sometimes in the hallway of an emergency department, deliver the highest quality, evidence-based care that has the highest chance of making a meaningful difference and reducing risk of suicide death? We know that there are treatments and therapeutic approaches that work to reduce risk. How do we support the right person to deliver these approaches to the right child at the right time? Put another way, the challenge is, how do we maximize the chance that providers will deliver evidence-based care that has the highest chance of reducing risk of suicide? When researchers started to approach this question, the first efforts focused on trying to develop a highly precise algorithm that would predict the risk of suicide death of an individual. And generally speaking, this did not work. The predictions were too imprecise and frankly, at times biased. In fact, now more modern approaches to this challenge focus on collaboration and delivery of evidence-based strategies that personalize an approach to patient care and safety. This challenge also emerged in conjunction with another phenomenon that has really grown over the last 2 decades, and that is the vast increase in health data and the interest in using these data to improve delivery of care. In 2009, the HITECH Act incentivized healthcare systems to adopt electronic health records. These are software programs that providers use at bedside or in the clinic or in the hallway of the ER to record information about that visit with the purpose of communicating that information to other providers for purpose of coordinating care and also for billing and coding purposes so that they might receive reimbursement for services provided. But since 2009, these software systems have evolved. And one of the major ways is that EHR's electronic health records are no longer seen only as a repository of information or a database that stores medical information, but also as a system that supports providers in making decisions about a patient's care. So when you or your child receives medical care, the chances are that the provider in the room is using an electronic health record that is likely prompting them with some guidance on clinical decision-making. This can be as simple as if you walk into the emergency department and you have a fever, the electronic health record will appear differently to the provider to alert them of the elevated temperature. So there might be an exclamation point or blue text or something that tips off the provider that there's a problem that needs to be addressed. In fact, the fundamental theorem of informatics is that the clinician's brain and the computer together are greater than the brain of the clinician alone. And if any of you use a smartphone or a computer and you use reminders or calendar notifications, you've experienced this theorem in action and the potential benefit of having technology to remind you of things. When an electronic health record provides specific guidance to a provider, we call this clinical decision support. It supports the provider's clinical decision making. Similarly to your phone notifying you of events or reminders, decision support can be helpful and convenient or a nuisance, and in the worst case, harmful. So connecting the dots, there's many illnesses for which electronic health records deliver helpful guidance to providers and in turn improve outcomes for patients if done right. So one example of this is sepsis or overwhelming infection. An electronic health record can use software behind the scenes that looks at things like white blood cell count, temperature, and delivers recommendations to the provider to address the sepsis and quickly. As you can imagine, prevention of suicide and suicidal thoughts and behaviors could fit within a clinical decision support system, but there's also a lot of complicating factors. Suicide can be driven by varying mental health conditions, risk factors, modifiable factors, and we have this arc of evolution with child development. We also don't have clean blood tests and brain images that will help us make these differentiations. So we have a gap, we have a challenge between a public health crisis and a software tool that could potentially help and does help in medical care for other pediatric conditions, but really a failure of these two to meet in the middle. In order to be useful and potentially successful in closing this gap and helping providers deliver better care, decision support needs to follow the principles of the 5 rights. So this has been posited as providing the right information, so things like evidence-based guidance, to the right person. Is it to the physician or the nurse, to the right patient who needs it? Through the right channel, does it go through a patient portal or does it pop up directly to the physician? in the right format? Is it an email? Is it a pop-up? Is it an alert? At the right point in the workflow? Does your clinician get this information at the very beginning, at the very end, between visits? All of these things are important for the information to be useful. And if you don't think you're affected by decision support in suicide prevention yet, consider that when you use a search engine like Google and you put in the words suicide prevention, you're already being provided decision support. A number of folks wrote in saying, I work at a hotline, I'm a volunteer. And look, when we search for suicide prevention, even Google is saying, here's the number, call 988. And so we see decision support in society that is permeating our approach to suicide prevention. So in order to accomplish these 5 rights and potentially develop useful decision support tools, we have to take a step back and look at who. Who are the children who might benefit from this tool? How do we find them? And today I'm going to take you on a journey in the next 15 minutes or so of what we know and don't know in this area, and then leave you with thoughts on where the future's headed. So each of these slides represents a paper, and I have some key points from the paper and then my take on the bottom line, with the caveat being that my take may not be the author's take, but it's what I took out of it and think is important in terms of painting this picture. Okay, first paper, mental health service use before and after a suicidal crisis among children and adolescents in the United States National Medicaid Sample. This is Stephanie Dupnick's work in academic pediatrics that came out in 2021. And what her group did is look at data from over 90,000 emergency room visits. And what they found is that children who are seen for mental health reasons in emergency rooms and discharged often do not receive mental health follow-up within 30 days. Moreover, if a child did not have established care with a provider before that emergency, they only had a 1 in 4 chance that they had a follow-up 30 days later. So what I took away from this paper is that mental health related emergencies are a key point of intervention because chances are that child will not connect in the short term with specialty mental health care. So this is a key point where we have to do a good job of reducing in the moment that child's risk. Next paper, prevalence and correlates of suicide and non-suicidal self-injury in children, a systematic review and meta-analysis. Blue, JAMA Psychiatry 2022. This is a beautiful study that put together 58 separate studies, totaling 626 million children, and focused on pre-adolescent children, and really debunks this idea that pre-adolescent children are not experiencing suicidal thoughts or behaviors. In fact, they found that 15.1% of children experience suicidal thoughts, and that also there's attempts and non-suicidal self-injury are very real in this age group. What they found beyond that is that those risk factors and those modifiable factors, those protective factors, they're different for younger children than for older children. And my takeaway from this is that if we're going to deliver the right information to the right person at the right time, we will be making errors if we try to extrapolate from adults to teenagers and from teenagers to children. If we try to apply the same support system to an adult as to a child, and that we really need to think about the arc of development in these tools and how we find children who are experiencing distress and suicidal thoughts and acts. Okay. Technical paper, but bear with me because it has some importance, a lot of importance actually. Issues in developing a surveillance case definition for non-fatal suicide attempt and intentional self-harm using International Classification of Diseases 10th Revision Clinical Modification coded data. Okay, so what this paper did is something really important. It provides a list of these diagnostic and billing codes that a provider assigns at the end of a medical visit that say this visit was for suicide or self-injury. These are like little 5-6 digit numbers. You can see some examples here. And they're important because they're the most common way health systems monitor the prevalence and incidence of medical conditions. For example, the number of people in a health system who have diabetes or heart disease or asthma, and also for suicide. These codes are very frequently used to identify who in a population is coming in for medical care for suicide-related reasons. And in the absence of other information, this is what would trigger an electronic health record to appear differently and deliver decision support. And so getting these codes right is important, and figuring out the limitations of these codes is also important because it impacts how we think about adapting electronic health records to personalize for the needs of the patient. So Dr. Hedegaard in this paper also points out that, look, these codes are not perfect, and here are some reasons why these codes may not reflect all visits for suicide and self-harm. This was back in 2018, and since this time, the jury is still a little bit out on whether we can use codes to find everybody with suicide or self-harm or not. This is a really nice paper Greg Simon put out in JAMIA looking at accuracy of these codes, accuracy of ICD-10 encounter diagnoses from health records for identifying self-harm. And bottom line is, he looked at people who experience frequent suicidal ideation. So they frequent thoughts of suicide and they have an injury. Does the code assigned for that injury appropriately convey whether the person had some intention to harm themselves? And what he found is that yes, usually these codes do reflect intention to harm self in this population. On the flip side, we have this other paper, Suicidal and Self-Harm Presentations to Emergency Departments, Challenges of Identification Through Diagnostic Codes in Presenting Complaint. This was an Australian study. They looked at 2,500 mental health-related emergency department visits in adults. The Simon study was also predominantly adults. And what they found is that actually these codes had very low sensitivity. They were not picking up the attempts or the acts. And they also found this signal that maybe there's some bias going on, that ICD codes are detecting a higher percentage of Indigenous people and of non-suicidal self-injury among women. And so something that they called for codes to be used with caution, that maybe in these emergency department data sets, we can't just rely on the codes. So different methodologies, different approaches to the problem, and kind of pointing at the idea that there's still some uncertainty here. One area that folks are agreeing on is that there have been increased efforts to see if we can go beyond codes, beyond kind of one 5-digit code that a doctor assigns at the end of the visit, and say, can we use more information from the visit to get a better sense of whether this child was experiencing suicide or self-harm? And the way we do this, the way that we look through all of the data associated with a medical record to try to figure out if somebody has a medical condition or not, is called EHR phenotyping. And this was a paper that Liao's group put out, kind of a classic paper in terms of saying, look, medical records, and this is back in 2015, they have lots of information, ICD codes, but also medications, vital signs. You know, if somebody comes in the emergency room and they have a very high blood Tylenol level, there's not that many things that would cause an elevated blood Tylenol level other than an overdose on Tylenol. So, you know, maybe we should look beyond just the codes and start to look at other signals or clues to figure out who's coming in with a suicidal ideation or behavior. Okay, so in order to develop a phenotype, to be able to take a child's coming in and say, okay, is this person here for a suicide-related reason or not? We have to be able to use a program that can learn the properties of the phenotype from many examples. And this process occurs through what's called machine learning. And in case this sounds overly technical, the concept is relatively straightforward, and it's that your email system uses machine learning to learn the properties of your emails and classify them as work or not work, spam or ham. And essentially a software program uses lots of data, lots of examples, and it says, okay, then for a new example, where does it fit? Does it fit into the work or the non-work bucket? Similarly, person coming in, do they fit as somebody who has X disease condition or Y disease condition? And this approach has been used now in many different conditions in psychiatry, bipolar disorder, depression, ADHD, and other pediatric medical conditions like ear infections, joint disease, cancers. But it's not been applied as much for children with suicide-related visits. And so this is the pilot study that we conducted that tried to assess and build a phenotype for children with suicide-related emergencies. So assessing detection of children with suicide-related emergencies, evaluation and development of a computable phenotype approach. So what we did is we asked, okay, how are self-injurious thoughts and behaviors currently detected in medical record data? Who is being missed and why? And how could we maybe be more accurate and more fair in terms of who we are detecting? In the short term, this has impacts on how we think about prediction and prevention of suicide in childhood. And in the long term, it gets at those 5 rights. Are we finding the right child that we're delivering this evidence, potentially delivering evidence-based guidance toward their care? Okay, so in this pilot, what we did, we looked at the records of 600 children with mental health related emergency room visits, and we read all of the notes and de-identified notes and tried to classify on a clinician, a human reading the note, would they say that visit was related to suicide? And we compared that to whether they got a code or not, and whether they came in the door saying that they were here for a suicide-related reason. In other words, had a chief complaint related to suicide. We compared this gold standard manual chart review with these existing methods, and then we tried out some of these machine learning models, these classifiers that took into account other aspects of the patient's medical record. This is just to point out that when we reviewed the records, we didn't simply say, is it suicide or not, but actually thought a little bit more in terms of what is going on. Is it thoughts? Is it behaviors? Is it preparing? To see if actually, can we develop a system that detects where in the sort of risk trajectory a kid falls? Are they close to acting, or are they having thoughts without having prepared? And to kind of have some nuance to differentiating these things. What we found in the pilot study is that ICD codes and chief complaint were very imperfect at detecting children, that they missed a lot of kids, and that using the machine learning based approach was more sensitive. But beyond that, and I put an asterisk here because it really called out to us, not all children were detected equally. Specifically, boys and younger children were less likely to be detected correctly. So this led us to expand our study and instead of looking at 600 children, look at 3,000 children. And we're asking the question, who's being missed? Maybe why? And how can we do a better job of being more accurate and equitably picking up kids who are coming in for suicide-related reasons? This is a picture that it's paired with the next slide. And what I'm showing here are the diagnostic codes for children coming into the emergency room. And what we found is that young children, 6 to 12, they're coming in with very different presentations, very different reasons than older children. And so this is one of the first things when we got to this larger 3,000 person sample, we started to notice that the young children look very different than older children, and they have unique needs. And if you're a parent, you're saying, yeah, no kidding. But the younger children, they were there for things like ADHD, this catch-all mental health symptom group, disruptive impulse control and conduct disorders, developmental delay, autism. And in teens, we saw many more depressive disorders, anxiety, substance, a different picture. And so when we went to compare different approaches to find suicide-related visits, one of the questions that was kind of top of mind is, do children, are they detected differently? And do current methods of detecting suicide-related visits in pre-adolescent children, are they not performing as well as when they go to detect in an older child? So what we did is we compared the diagnostic codes in chief complaint, kind of the existing standard, with this machine learning based approach in this bigger sample of kids. And what I'm going to show is preliminary data, because our sample, we currently have 2,700, and we're building toward 3,000. So most, but not all. Okay, so when I show the results, I'm going to show a series of graphs, and this is probably bringing you back memories of maybe statistics 101. So not to make it too painful, but okay, in order to figure out whether a program that's supposed to classify, that's supposed to say, is this person here for suicide or not? If it's a coin flip, we end up with a graph that's really close to this diagonal line that goes through the middle. If the classifier is perfect, it can always tell you whether or not somebody is there for suicide, and it's always correct, we're up here in this top left corner. So the red line, if you're in the middle here, straight across, that's chance. That means your classifier is terrible. Put it back on the shelf. Don't put it in the EHR. If it's up here in the corner, it's doing well. And maybe we should think about whether this is useful in informing, informing decision support in action. Okay, but we have to get up here, this top left corner. So what do we find? Again, my caveat, this is preliminary data, but in the old system, so if you use the codes and the chief complaint, you end up with a curve that looks like this one in the top left. So the blue background is the old system, and the orange background is new. When you use a more detailed approach, when you use this classification approach, we see this bump that classification improves, that we go from not being able to detect as well to detecting much better. The other thing to notice, and the font is a little small, but if you can make out, this top line is girls, the orange line is girls, and the green line is boys. And you can see this green line of boys is there's much poorer detection among boys than among girls. It's closer to chance. Okay, and when you use the machine learning classifier, although the performance improves, this gap remains where we're still not detecting as many boys. If you divide up the sample by race and ethnicity, and you use the code-based system, the old system, there's a lot of variation there, where Black and Hispanic youth, this green line and this red line, are not being detected as well, that there's more errors. And when you apply a more holistic approach to classification and you consider other aspects of the medical record, you actually get better detection for everybody. And these colored lines are closer together, meaning that we have less variation in terms of who we're detecting. Another finding is that children are not detected as well. So these curves are all 6 to 17, all comers, all 2,700 children across the age range. If you restrict to kids 6 to 12, so pre-adolescent children, this curve drops closer toward chance. And in this smaller picture, I show the relative improvement with using the machine learning based model. Again, you keep this gap between boys and girls, but our detection gets more accurate in children. So To me, this suggests that younger children, we're missing them, that using the codes is likely not sufficient in picking up 6 to 12-year-old children. Another gap or finding from this is our capacity to detect non-suicidal self-injury with codes alone and chief complaints. So somebody coming in, the first thing they say when they walk in the ER, or whether they got a code, if we're trying to detect non-suicidal self-injury, it's very poor. So again, this dotted line, that's chance. We don't want a classifier that looks like this, that we shouldn't put this in an electronic health record to deliver decision support. It means it's not picking up kids who are coming in for this reason. And this to me is important because trying to intervene on trajectories of non-suicidal harm is different than intervening when somebody has intention to die. So this is, I think, a clinically relevant finding that there's this gap here. Okay, so how do we do better? A number of studies, all these yellow boxes, have explored the idea of if we can do a better job using notes. So providers, we tend to write probably too long of notes. And you might argue too short of notes, but nevertheless, there's a lot of information in there. And so the kind of where things are headed is that a lot of people are looking at these notes and saying, can we develop machine learning models that use natural language processing that incorporate these notes to try to help detection? And the bottom line of all of these papers is, yes, notes likely do help, but challenges remain, and head-to-head comparisons of new and existing methods are scarce. So someone will come up with, this is this new model for detection, and first question is, okay, does it do better than what we already have? And so we're working on it, and there's lots of interesting things coming out here in terms of using indications in notes. This is just one example of Rosova's paper in 2021. They tried to apply a natural language processing system, and they compared it to using keywords. If you use like control find on your computer, and that yes, using a machine learning system, a natural language processing system, it's dramatically going to outperform a keyword search. Okay, now I'm going to pivot and talk about challenges. And I'm going to try to organize these challenges into 4 buckets. Beyond these 4 buckets, there likely are many more challenges. And certainly if there's ones I don't get to that you're thinking of, please reach out. You can comment and we'll talk about it, because there's a lot of challenges here actually. Okay, so first one, what I call the stacked deck, algorithmic fairness. Okay, we'll talk about that. Then moving target, childhood development occurs along an arc. We have this leaky pipeline. Good software is not necessarily good care. And then ethics, right? Health data use and the slippery slope of using routinely collected healthcare data. Okay, so algorithmic fairness. In the process of developing a software program, a program that learns to detect suicidality, make predictions, and offer guidance using data from the given population, individuals in that population who have different characteristics than the majority are more likely to be misclassified and mispredicted. This is a statistical phenomenon that has big implications for whether decision support tools are fair and work well across diverse populations. Put another way, we have to be skeptical when evaluating decision support tools and associated software. Who was the software developed for, with whose data, right? Your email inbox learns to classify emails. If you use a different inbox, you're going to get a different classification system, right? So was the software adequately trained to detect or predict or offer guidance in the population of interest? Without this skepticism and testing algorithmic bias, we risk perpetuating existing inequities in care, right? We risk not doing a good job predicting or classifying risk in certain groups. And we saw that in our study, and it really is a big concern that if your algorithm is not fair, there's a problem. Relatedly is the issue of a moving target. Children change with time, right? Presentations of psychological distress and suicide vary tremendously over a short window of years. For example, manifestations of suicidality may not differ much between a 40-year-old and a 45-year-old, but the way somebody looks when they're in distress and they're 10 is very different than when they're 15. So when we evaluate decision support, are we detecting children and providing guidance in a developmentally appropriate way? Or are we training our predictive models and training our data sets, lumping 10-year-olds and 79-year-olds? There may be static risk factors that don't change with age, but an approach needs to be nuanced to distinguish these. Another challenge is this leaky pipeline. The vast majority of detection and prediction models and fancy algorithms sit in file drawers and never make it to clinic. And most decision support tools, most tools that are implemented into the software that your provider sees, are developed to meet the needs of the health system and are not necessarily grounded in strong scientific evidence and rigorous statistical evaluation for performance, for accuracy, or for fairness. So health systems are starting to have some oversight over what tools get embedded and whether those are grounded in evidence. And researchers are pushing toward actually getting some of these tools in practice and measuring, are they working or not? Are they helping or are they causing harm? So this crosswalk is new and it's growing. Then we have the slippery slope of ethics. Quality assurance and research rely on systematic collection and analysis of data from patients. We also have an obligation to ensure privacy, confidentiality, and ethical use of this data. And where this gets complicated is that as decision support software and detection algorithms get more and more complicated, technology companies increasingly are merging with the healthcare field. And so we have to be really careful. What are the implications of using this health data to develop methods to help people in future visits? Are we using the existing data ethically? Also, from an ethics standpoint, we have to think critically about what are the implications of using somebody's past records to share information that's tailored to reduce their risk of future events. Particularly for children, it's not just the patient and the doctor in the room. There's a parent, there's a third person, there's a caregiver. And who gets what information? Does it go to the parent? Does it go to the child? Does it go to the physician? And who wants what information? It gets very complicated of how we do this ethically and appropriately. Okay, some views on the roadmap ahead, and then I will have some time for questions. Okay, so where are we going? What's happening in the next 5-10 years? One, I should put this in quotes, smarter algorithms. And what I mean by this is that our health data gets larger. We're getting more communication between health systems. Natural language processing evolves. If you hear the news, you're constantly hearing about generative AI and chat GPT and large language models. And there's sort of this explosion in getting more and more complicated algorithms, which is really cool from a capacity to dig into existing data, but for the reasons that I've described in this talk, requires some skepticism too when we're thinking about how these algorithms are growing. Another way that things are changing is an increased awareness that electronic health records are not only for providers, they are really there for patients. And that information should go directly to patients through portals, through ease of access to their medical records. But it also means when you're delivering the right information to the right person at the right time, the patient is part of that. And so are they, who receives what information and when is becoming an area where we're thinking more outside of the box, that it's not just a tool that goes to the clinician, it's a tool that can be used by the family. Okay, the next area that's growing a lot is community perspectives, which is that we would be very remiss as scientists to develop tools or look for insights in health data without foundationally including the perspectives of the people who seek to benefit from this, from our endeavors. That we need to have the perspectives of community members, of people with lived experience, of kids who are experiencing these things. You know, it's very important to integrate and understand, what do providers want, what do parents want, what do kids want, and when are these things different? Because often they are. That we really need a community perspective from the beginning. And I think this is growing. This is something people are trying to do. And then finally, another way that things are growing is adding data from the real world. So the title of my talk says real world clinical data, but really clinical data is not the real world. The real world is beyond the exam room, right? The real world for teenagers is social media, it's their smartphone, it's schools, it's internet browser and search data. That there is a huge increase in all of this data beyond the health setting. And so a lot of folks are thinking about, you know, ethical use of social media and trace indicators of, you know, how do people express distress on social media and what to do in those cases. So there's a lot of interest in using other real world data sources, sometimes actually put together with electronic health records. And then thinking beyond the doctor-patient relationship, that you know, nurses deliver often universal screening for suicide, things like the Columbia Suicide Surveillance System, these short questionnaires that are given, we call it universal screening. So it goes to every person who walks through the door in the emergency room. You'd think that using those questionnaire responses would help us find people who are experiencing suicidal thoughts and behaviors, but actually they're quite poorly integrated into detection and surveillance systems. That we have this disconnect between the efforts that nurses are doing and in getting this data to translate to real world changes in medical records that can help patients. I'll also add here that, because a few folks put this in the questions, of suicide hotlines and crisis intervention support. And one of the questions I've been really interested in is, can we detect when somebody used a hotline before they presented to care? Did using that hotline drive them to present and to get help? And right now, our ability to query medical records to figure out the role that hotline and other crisis intervention services are playing is still very limited, but I think it's a really cool area to grow in, and one that meets the efforts of our community in the middle with a lot of the efforts we're doing on the data science end. Okay, so some takeaways to leave you with. Suicide is a highly prevalent condition for which personalized medicine offers hope. If there's one thing I can instill by talking at you for the last 46 minutes, is that there is hope that things are getting better, that our tools are getting better to meet the needs of people who need them. And with this idea of personalized medicine, patient-centered care, that every day we're getting better and better at delivering personalized support to patients, providers, to kids and families. And while we are improving, we also have to be very aware of our faults and limitations, and that current methods to detect need may be inaccurate or biased, and children are a moving target who have special considerations that they evolve over time. And better detection of healthcare visits related to suicide may refine our precision and our capacity to intervene early and change the lives of kids experiencing distress. So thank you for your attention. I think we have about 10 minutes left for questions. I've also put my speaker contact information on this slide. Please reach out if you have any questions. I'm happy to talk with anyone interested in this area.
Juliet, I want to thank you for really an outstanding presentation. Great overview, a lot of information, and you did it in a really very user-friendly way so that lay people can understand it. So thank you very, very much for that. I want to ask you a little bit about, once the data is available, once we know someone may be at risk, what are the types of interventions that may be available to help that child or adolescent who may be showing some of this risk?
Yeah, absolutely. I think one of the major things we can do is distinguish when somebody is at risk. Okay, at what point are they in that risk trajectory? So there are certain interventions that we want to have delivered in a general setting. So for example, in a pediatric primary care office, when someone first starts to show signs of distress, perhaps a decision support that would promote getting that person connected to mental health services. So for example, a younger child, they're showing some signs of distress, but maybe not even suicidality yet, just some sign that they need to talk to someone, anxiety, mood symptoms, and prompting the pediatrician or the pediatric provider, look, here are referrals in this person's geographic area. We can use things like zip code, patient's address to say, here are some options that can be provided in the general setting. On the flip side, you could take somebody who's in the emergency room, who's there for suicide and self-harm. If the electronic health record picks this up, perhaps they are prompting the provider to talk about lethal means restriction, getting dangerous means for self-harm out of the house. That gives the provider some support in talking about that. We know reduction in access to firearms can significantly reduce suicide risk, giving the provider some language around that, how to support the family in reducing the child's risk. So I think it really depends on where somebody is in their trajectory. And that's one of the reasons we, these 5 rights, right information, right person, right time, because it really does differ depending on the specific needs of the individual and where they are in terms of how we can help them.
Good. No, very, very helpful. And I want to ask you about a topic that there's often a misperception, which is in asking somebody about suicide risk, suicidal thoughts, it may put that idea in the person's mind and increase the risk, when we know that asking about it can potentially save a life. And I'd like you to speak toward that.
Yeah, absolutely. So as you mentioned, I mean, the idea that asking about suicide increases risk has really been debunked. That instead we should be asking, if you see somebody who's in distress, whether that's in your personal life or if you're a clinician, you got to ask, and providing that person with some places to start in terms of getting help. I said a few people responded who work in crisis hotlines. I think everyone should know 988 is the number now to call suicide crisis hotline. There's also a crisis text line. I also work with a wonderful organization that is called Teen Line, and they actually have a hotline staffed by children or for adolescents who respond to calls from other adolescents. So if a kid calls in distress, that they'll provide support actually from another teen. And as we know, adolescents are much more likely to talk to each other and tell each other. But definitely asking is so important. particularly if you are a provider, but if you're a teacher, if you are a parent and you're worried, please ask, in an open-ended, non-judgmental way. That's going to increase the chances that person gets help.
Very good advice. And let me take sort of it a step further. So if a parent or a teacher is listening right now and they're concerned about a child, what are the words they should use? What's the best way to approach this?
That's a good question, because it varies a lot based on, the age of the kid and their relationship. But starting off kind of saying, I've noticed things have been down lately, or, what's going on, and just kind of opening up the conversation of checking in. And then you do want to ask directly, are there times where you feel like you'd be better off dead? Are there times where you think about ending your life? And you don't want to use a euphemism, like passed away or fall asleep and not wake up. You want to try to be pretty concrete, especially for a younger child. And that conversation can feel really scary as a parent. But again, you're not going to create the idea in the kid's head that children who experience distress, we as parents, as caregivers, as teachers, should be asking these kinds of questions.
Good, very good guidance. And finally, I want to ask you about the issue of what's referred to as contagion, where one suicide in a school or even in a famous person can lead to others thinking and maybe acting upon those thoughts of suicide. Could you speak a little bit about that, please?
Yeah, that's a really good point. A few thoughts on that. First of all, knowing somebody who has completed suicide is a risk factor for suicide in individual. So, for example, if you have a child and their classmate dies by suicide, your child is at increased risk. And so you should, again, just going back to what we had just said, that checking in and providing mental health support when you know that there's been a suicidal loss that somebody has been exposed to is important. Beyond that, when we think from like a public health data standpoint, one of the reasons it's so important to pick up when people are coming in for suicide-related reasons is that we can see from a bird's eye view, within cities, counties, states, where are we seeing hotspots? Where are we seeing almost like an epidemic, right? We saw this with the COVID-19 pandemic. We need to know kind of where things are happening so that we can reduce risk of contagion and provide support. So there was actually a surveillance system that was deployed. Now I'm not remembering the state, but what they did is they were able to detect visits, and that the visits were increasing for girls who were overdosing. And so from a public health standpoint, they were able to advocate for pill bottle locks to reduce risk of overdose death. So it was a targeted public health intervention that used the knowledge that there's more overdose deaths in a certain population to then try to intervene. And so the kind of incorporating that geographic data is important. And then finally, when we think about natural language processing and text, I've read and written many notes from kids who are coming in for suicide-related reasons, and kids will mention things like, oh, I watched 13 Reasons Why, or I had a classmate attempt suicide. And if we can get better at detecting these signals within notes, we may be able to get better at sort of stopping these the effects of the contagion, because we'll be better able to identify what are the precipitating factors.
Thank you. Excellent information across the board on such an important topic. I appreciate the research that you're doing and sharing your perspective with us. So, Julia, thank you so very, very much.
Of course. Thank you all.
Also, I want to thank everybody as well for joining us. And please consider making a donation to BBRF. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that when you donate a dollar for research, that dollar goes directly to the scientists. To make a donation, please go to our website, bbrfoundation.org, or call 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the webinar and would like to share it with someone, please visit the events and webinars page on our website. And please join us again on April 9th at 2 p.m. Eastern Time when Dr. Autumn Kujawa, an associate professor in psychology and human development at Vanderbilt University, will present Enhancing Positive Emotions to Prevent Depression in Youth. Thank you all again, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Thank you.